Is that correct?
So I have nothing to disclose.
Undisclosed.
So this is the scientific integrity comments that I will stick to here today. And this is the agenda for today. So I'll do the best to talk about some EP trials in 2025, which was actually an exciting year. So this is a lot, granted, but we'll do a little smattering of everything. So, you know, if you want to think about it, this was the year of PFA and has been and will be. We're all living in a wonderful PFA world. But I'm going to talk about other things throughout the course of this trial because I think there are some trials that I'll talk about which I think will change practice. Okay. This is the one, if you're going to take a nap, please take a snooze right now. And the reason why I say that is because this is the European HRS, which tried to update their guidelines a little bit about antiarrhythmic therapy. And why do I say it's snoozing? Because we're trying to get away from meds, right? That's what we're doing at EP. We're trying not to use meds. So essentially, this was a 91-page document. And I think I can drill it down to something very, very quick because essentially what they tried to do was make antiarrhythmic medications a little bit more palatable. So the very first thing they did was they changed and they simplified. This is why people don't like EPs. This is the simplified version of the description of antiarrhythmic therapies. So essentially, the Vaughan Williams classification is something that most of us are kind of familiar with. So essentially what they tried to do is introduce some new groups and, you know, some of these medications that we're going to be very familiar with. So just so you know, in your practice, they did try and update the guidelines with more descriptive terms for antiarrhythmic therapy. Then what they did was, this was the summary advice on how to use antiarrhythmic medications. Again, why do people not like EPs? It's because this is the summary document. This is what I would like the summary document to look like, which is, if you are interested in knowing what meds that you can start in the hospital and should start in the hospital, or you should feel safe in your outside practice starting, in hospital, they're the ones that we kind of know, dofetilide or Donaldson. That's an in-hospital initiation of medications. Class 1A antiarrhythmics, most of us don't use quinidine or backbone, and those should be started in the hospital. I like this because this next comment, which was, how do we use sotalol? So many of us use sotalol in our practice, but when is it safe to actually initiate sotalol as an outpatient basis? And it really helped say that if you have any of these criteria, you should start sotalol in the hospital, which is QTC greater than 450 milliseconds, reverse use dependence of sotalol increases the risk of malignant ventricular arrhythmias. If you have an interventricular conduction delay 500 milliseconds or bradycardia, heart rate less than 60, again, reverse use dependence, increased risk of torsades, or other risk factors which include renal insufficiency. This is a renal medication. I like this part even better because outpatient initiation, it's easier for our patients. It's less cost prohibitive. So in certain medications such as dronedarone, amiodarone, and in patients who have never had any structural heart disease, and sotalol could be safely initiated, particularly in patients who are in sinus rhythm, no sinus bradycardia, normal kidney function, and no real conduction problems. And that's sometimes we struggle, should we safely start sotalol. Let's talk about this next trial, which is called the Advantage AF, which was a phase 2 trial. Again, there's a lot of stuff in these slides. I have all the references, so if anyone's dying to read the paper, I actually brought copies of all the papers I'll talk about today. Okay, so this was a publication with Vivek Reddy. Essentially, it was looking at pulse field ablation. So several ways to treat AFib from an ablation standpoint, most of them thermal, freezing, or burning. This is not thermal. So this is pulse field ablation. And essentially, this looked at pulse field ablation in people who not only were going to have pulmonary vein isolation, but they're going to do additional lesion sets. And then how do we actually monitor these patients afterwards to kind of look at their results? And the nice thing about this was that you can do other ablation sets. So this includes the posterior wall or cavo-tricuspid distance. So this was a nice study because it actually started to look at that technique. So a lot of people are doing this. This is a study that actually looked at it. And the way they kind of looked at it, this is a lot of the patient information. Again, we're going to take a little more higher view of that. But essentially what it looked at is the outcomes, including device monitoring. So this wasn't just, seeing a patient in the office and are you having symptoms or not. This was actually looking at episodes of atrial fibrillation, and this was actually detected on implantable devices. And the outcomes were actually really impressive. So what are we actually looking at? Episode duration greater than 24 hours. So the incidence of that occurring is very infrequent, so 6%. If you actually go super, super strict, so we're talking 30 seconds or more of atrial fibrillation, anything less than 30 seconds, pretty much probably not. Our outcomes are still actually quite impressive. And the reason why this was a great study is, number one, it showed the feasibility of doing this procedure, that you can use this technique, which was it's called a pentasylin catheter through pulse field ablation, to do what's called a cavo-tricuspid isthmus ablation. To do some precautions with that. Ablate the veins and also doing some posterior wall, and the success rates were excellent. So this was a great trial in 2025 because it talked about the feasibility of using these new catheters and strict follow-up. Let's talk about another AF trial. This is called AF. Interesting catheter design. So this is a catheter to deliver pulse field ablation. And that's what a lot of these trials are doing. Experimenting, every company's going to use a different kind of catheter. So this catheter is visualized right here. So essentially this is what's called large tip focal pulse field ablation. And this was the company's catheter they devised. And it's kind of a novel catheter, and it can deliver large ablation areas and also has mapping capability. So one catheter, therapy, and mapping, which is really exciting. So this was a trial that was performed in the United States and Australia, 440 patients. And essentially what this trial was looking at is, can we do it? Can we do it safely? And what are the outcomes? Again, a little bit more about the actual delivery of these lesions. But what do the results show? Essentially, you go in with a catheter, you perform pulmonary vein isolation. This is not new. It's been around since 1998, so this is not anything new. It's just additional catheter. And the acute success rate for pulmonary vein isolation, what is that defined as? Catheter, delivering lesions, map, looks good. Reinterventions acutely, very infrequent, and what we call pulmonary vein isolation durability. You send a patient for an ablation, you will ablate the veins, come back and look, you're still open. Pulse field ablation does a very good job of that. So, in their safety protocol, they do have some outcomes, vascular access complications. It's a little bit bigger, so the larger the sheath, the larger the catheter, more likely to have vascular complication. But here's one of the big take-home points. If you send a patient for pulse field ablation, the likelihood that you're going to have pericarditis, non-thermal, less destruction, or targeted, less pericarditis, one pericarditis episode in all of these patients. Pulmonary vein stenosis, dreaded complication of other thermal techniques. We're not seeing this here. And esophageal injury, another thing that we really, really worry about. You're not seeing the pulse field ablation with this catheter. And when we kind of think about damage to other structures, the phrenic nerve is another big one. We're not seeing that. So, an exciting trial. Let's jump to devices. Praetorian was a very nice follow-up study to look at the safety and efficacy of a subcuticular ICD. It was compared to a transvenous, a standard ICD. In these people, they have no indication for pacing. So they have a subcuticular ICD. This is going to be a primary or secondary device. And one of the things that they looked at is, are these devices as effective? What are the complication rates and the durability of this little knee right here, which goes underneath the skin, doesn't touch the bottom part. And the nice thing is, orange is a transvenous ICD, and these are all complications versus a subcuticular ICD. And it would look like the subcuticular ICD in this pre-specified population. Again, no indication for pacing. With this device, you cannot pace. Complication rates, minor complications, very, very comparable to each other. And major complications, it usually has to do with the leads. Whether it's the durability of the leads or lead complications, this device performed very nicely. Let's talk about another trial, which is called the I-CLASS trial. So I'm sorry I'm going fast, but I want to get through a lot of stuff. What's the iPlus trial? So this is really exciting. Once again, on a device standpoint, our goal is to accomplish several different things with wires in the heart. You can pace the heart. You can do this more physiologically, which means not at the RVA base. So if you pace the heart, you're engaging the conduction system as much as possible. Well, we're going to have a technique that will compare standard techniques, which are 1, 2, or 3 wires, with the third wire going in the coronary sinus. So this allows for maintenance of synchrony, left ventricular posterior lateral wall, and the arc septum. So bring those two chambers together very nicely. That would be what's called CRT, cardiac resuscitation therapy. Let's compare this to a new kind of what's called conduction system pacing, where we actually put a wire, we actually try and engage the normal conduction system. So the goal of this trial was to compare biventricular pacing with conduction system pacing. Some of the things that they looked at was primary outcomes, which is death and hospitalizations for heart failure. Those are big metrics that we want to look at. So green, this is like a vision test for you. Green is conduction system pacing versus IV pacing. Primary outcomes, which is death or heart failure hospitalizations in patients who have an inherent left bundle branch block. Conduction system pacing versus IV pacing. This is all the patient characteristics. And, I think these are very well matched and very strict criteria for what sort of outcomes in these patient populations. Essentially, what we saw was with very strict criteria that conduction system pacing was actually associated with improved clinical outcomes, which is really important for us compared to IV pacing. And I think this is yet another trial that's going to kind of push electrophysiologists to offer conduction system pacing, which is what I do. All these trials utilize wires. The more wires, I like to think of more problems. So more money, more problems. So leadless pacemakers are a way to avoid that. Leadless pacemakers have been around since 2015. You see them here in practice. But are there any advances in leadless pacemakers? This is a nice trial from Vivek Reddy. And really, this is the first in human feasibility of a unique device, which essentially is going to look at the safety and performance of what's called a helix-based leadless pacemaker with an extended electrode to engage the conduction system. So the reason why I put this study after this last one was conduction system pacing makes sense. Can we do this with a leadless device? And this is a preliminary trial. These numbers, more of a, shall we say, feasibility trial. This is the device. So essentially, this is a leadless pacemaker, which you can introduce with a large venous sheath. And it actually has a deployment which goes to engage the conduction system, so that's the smaller one. And then this screw, which actually goes into the myocardium. So it's got two. One that goes into the conduction system, a separate one that actually attaches to the myocardium. The company that makes this already has a leadless pacemaker, and it kind of looks like this device, but without this. This device is implanted in the high septum. And what's it look like? Okay. I apologize, this looks like a lot of stuff on the screen, but let's just maintain our sight on this, which is the leadless pacemaker. So everything here with the active fixation mechanism, you're going to try and implant it on the interventricular septum. The concept here is, can you safely deliver a device with little in the way of wires that can engage the conduction system? No wires, battery pack, life gets a lot easier. The concept here is that if you can engage the conduction system, that QRS is narrow, and you have less disintegrating. And what did they show? Well, that their initial results, and please take this with a tincture of optimism and not pessimism, 14 enrolled patients, so it's a small. Conduction system patient was successfully inserted in 10 patients. So again, you're probably thinking to yourself, I've already tuned out. 4 people didn't get the device. But this is early technology. And the pacing thresholds were a little bit high. Other metrics that we look at looked a little bit dodgy. But I give Vivek a great deal of credit for taking this trial on, and I think we'll see more of this in the future. So my optimism is high, and I love anything that's like this.
How long will it last?
What's that?
How long will it last?
Oh, so those battery statuses? So the way I'll answer it is, if we take the platform, which is what their current device is, which is basically a single chamber device. They also make a dual chamber leadless. But their single chamber leadless pacemaker see well over 10 years on these batteries. So the hope is that if you really screw that into the myocardium and engage the conduction system, thresholds should get better. So this is their first iteration. I will tell you the battery stats on this device is several minutes. But that's a great question. Because maybe if I could follow up with another question on top of your question, is how do you get these things out? So for this product, one of the beauties is it's retrievable.
Wow.
So if you actually
For a certain amount of years, though?
So the theory is that, and so yes, the theory is this has a little deployment knob on it. So what you can actually do is go with a lasso catheter on the back, deliver your sheath. Because this is extendable, retractable, you in theory should be able to actually take this out. So that's a great question. Okay. Let's go back and talk about how do we treat someone who has LV systolic dysfunction, their risk of sudden cardiac death, and they have dysynchrony. So we're talking about 2025, we're talking about potentially 3 wires. An atrial, an ICD coil in the right ventricle, and then some sort of third wire, whether it goes from the coronary sinus or conduction system. Again, a lot of hardware. Is there something that we could do differently to try and combine some of these leads? This is something called the leader left bundle branch area pacing clinical trial. Okay, so again, this is a little product specific, but if you want to focus in on the concept as opposed to product specific things, this is a great trial. So essentially, you need to deliver multiple different leads. Is there any way that you could combine some of these wires together so they're dual purpose and make them smaller? I personally get very nervous when companies talk about smaller leads, but you have to push the envelope. So what did this trial look at? A special kind of lead that did actually 2 of those things together, which is deliver a shock, a coil, and do physiologic pacing. Okay. There are very strict criteria which to say that you did appropriate positioning of this lead, which I listed here. But let's talk about this. So this is, if you will, a combined lead. It's called Omnia Secure. So defibrillator lead and pacing built into one. So this is the lead. And most of you, if you look at chest x-rays of your patients who have devices, you'd probably be a little concerned about that. Why? Because it just doesn't look right. That coil is usually, in this configuration, kind of mashed right up against the septum. So that when it shocks from device to coil, you catch a lot of myocardium. So either this was done intentionally or something's wrong. Well, this has been done intentionally. A standard lead, French, this is an 8.5 French lead, has this really interesting configuration. So you basically have your cables, and they can sense what the myocardium's doing. You can pace, and you can have what's called a defibrillation cable, which basically goes to a coil. And you can have 2 of them. This is a standard sort of configuration of an ICD lead with all of your patients. This is a newer lead, which actually does not have an air lumen for us to position the lead. It actually is stripped down and much smaller. And this is the lead position so that it can do 2 things. period can shock the myocardium and deliver pacing to the heart. The results, pretty impressive. The durability testing of these wires was really impressive. They stressed them in machines. It looks like a paint shaker. So the durability looks good. It's benchtop testing because obviously you can't project out 15 to 20 years, which is what we really want to know. But 293 successfully implanted patients with 100% successful defibrillation threshold testing. And essentially, about 98% were free of any bleed complications. So newer techniques, very excited to see how this goes. This is called the leader left bundle branch areas. So this trial suggests that this is sure.
Is the microphone?
No. We're talking about pacemakers.
Oh, you don't need it on? Oh, okay. I thought
so
you said you couldn't get it on.
No, I think we're okay. But thank you.
Sorry about that.
Yeah, no. I'm glad you. That's okay. A good, engaged audience. I love it. So this is probably something that will resonate with everybody in the room. Why? Because we are seeing GLP-1 in all of our practices, and this is the one that I did the least information, which is paradoxically, you got to know your audience. Right? Anyways, GLP-1s in cardiology, it is really hitting its really high point. And I think a great question is, what about AFib, right? It fits with metabolic syndrome, it fits with everything that GLP-1s is reportedly helping with. How about AF? This is one of the earlier trials, so this is not going to give the answer that you want, but I'm glad that these trials are being done. So essentially, what was this trial looking at? It was patients who were going for AF ablation who had been using a GLP-1. So essentially, what did they do? This is patients undergoing an AF ablation, and from the real-time data was 2014 to 2023, so things evolved. But essentially, this is real-world database. And essentially what it looked was, in a one-to-one propensity score matched patient selection, patients who had used a GLP-1 versus not, and they've gone for an ablation. So basically, they're going for an ablation, and they just looked whether they had used a GLP-1. And then they basically looked at 3 to 12 months after the index ablation, and basically what the primary outcome said was fairly neutral. Now, this isn't the study that our patients want, which is, I have AFib, can you prescribe me a GLP-1? But I love the fact that someone's doing these trials. So, early, but I'm glad someone's doing it. Next, this is something that I think will resonate with every single person in this room who sees a patient who has AFib, which is, what do we do with oral anticoagulants after an AF ablation? So again, take anything home from me talking about pulse field ablation and all kinds of crazy lead stuff. This may be a time to say, ooh, this is an interesting trial. So Alone AF. This was a JAMA publication. It came out in August of 2025. So this was a South Korean-based trial. And their clinical question, I think, is really excellent. Most of us struggle with it. I know I struggle with it. Is in patients who have undergone an AF ablation and they have, let's just say, somewhat of an elevated CHA2DS2-VASc score. When can you safely discontinue their oral anticoagulants after an AF ablation? Because patients are asking. So what did this trial do? It was a randomized clinical trial, 840 patients, so pretty small. This was performed in South Korea, 18 hospitals, and their CHA2DS2-VASc score, as I mentioned, was greater than 1. And here's the only thing I will say about this trial and the very next trial, which is documented freedom from atrial fibrillation when you're at your catheter ablation. So if they've had breakthrough, this is not the trial. But if they're free of atrial arrhythmias post-ablation, I think this is an interesting trial, and we'll talk about another trial. So essentially what they did was they randomly assigned them to basically aspirin or no oral anticoagulants or continuation of their oral anticoagulants. And they looked at a lot of different endpoints. So they looked at something which is a cumulative incidence of positive strokes and systemic embolism or major bleeding. So this was their primary outcome. blue, oral anticoagulants versus no oral anticoagulants. This is 24 months out, so 2 years. So already you see immediate divergence, and it only gets more pronounced. Now, on the y-axis, this is very blown up, so this is really made to accentuate these, but let's look at cumulative incidence of systemic stroke and systemic embolization. Again, oral anticoagulants, no oral anticoagulants. But I think the big one for me was this one. Major bleeding. As expected, the longer you keep your patients on oral anticoagulants, you do have that yin-yang, the trade-off. But look at how it really kind of takes off. I mean, yes, it's a median. Did pretty well for a while, and then it really starts to take off. So the incidence of their primary and secondary outcomes really allowed the authors at the end of the paper to say that among patients without documented AF post-ablation, discontinuation of oral anticoagulants resulted in lower risk of composite outcomes of stroke, systemic embolism, and major bleeding versus continued oral anticoagulants. So, one trial, one country. Let's go to OCEAN trial. So the OCEAN trial, this was New England Journal, and this was Atul Verma, who was a very prolific researcher. I put this in the best of 2025. It was released online in 2025 and just came out in Harvard Press in January of 2026. And essentially, the whole question was, very similar to the last trial, was whether successful catheter ablation for AF eliminates the need for long-term oral anticoagulants. So again, this really has to be successful catheter ablation. So this is a great trial. International, open label, randomized, blinded outcome assessment trial of 1,200 patients. And they had all undergone successful catheter ablation, so like the last trial. They're a CHADS score of 1, so it's not a 0. And they were basically randomly assigned to either continue aspirin, so in this trial, a little bit different, nothing or aspirin last trial, this trial was aspirin, versus Xarelto. And they're followed for 3 years. This is an amazing trial. Look at what they did. They used MRI of the head and was performed at enrollment in 3 years. So this is not clinical. This is any MRI assessment for evidence of embolization. It's really impressive. So what did they do? Obviously, 1 year successful catheter ablation, randomized. I mean, they're really strict criteria for what is AF. Holter monitors, 48-hour Holter monitors, and their CHADS scores listed. Yeah. So essentially, what did they do? This was a Xarelto rivaroxaban trial. 15 milligrams versus aspirin. All patients received a baseline MRI, and then at 1 year and 3 years. This fell in the middle of COVID. Things got a little sideways, but they looked at some primary efficacy outcome and primary safety outcome. So essentially, what they're looking for is stroke, systemic embolism, or detection of anything seen on the MRI. This is really amazing that they did this. Primary safety outcome, this is fatal or major bleeding. And then the secondary was, these are sort of all these things put together plus more less severe bleeding complications. This is the inclusion criteria. Here's the only thing that jumped out at me. So their CHADS score, again, in this trial was basically, 1s 30%, 2s 30%, and 3. I think this is very perfect. 4 or more, it's really hard. You have a CHADS score of 4 to say that you need to stop your oral anticoagulants. So this is, I think, a really great population because this is a conversation you want to be having. This is how they were assigned. Basically, great follow-through. Very few patients lost to follow-up. This was a trial mainly based in Canada. And their outcomes, essentially, this was the cumulative incidence of stroke or systemic embolism. So this is the aspirin arm, and this is the Xarelto arm. And you would kind of expect that. This is the interesting part for me. So this is clinically relevant, non-major bleeding. Xarelto here, rivaroxaban here, aspirin here, and minor bleeding. And this is mainly self-reported by the patients. So here's your rivaroxaban, here's your aspirin. So what happened with the trial? The Data Safety Monitoring Board called them and said, you can include enrolling patients. Why? because as of 2022, they recommended that there was a high likelihood that the trial would not show benefit for continuation of the rivaroxaban. It was really to their credit. This is, you may say, well, 2022, why didn't I hear about this in the best of 2023? Is because they allowed those patients to complete the enrollment. So you enroll them, they followed up for 3 years, and now we actually have results. And here's the conclusion. In this pre-specified population, rivaroxaban did not decrease the rate of stroke, systemic embolization, or that major bleeding was not significantly different between the two groups, but clinically relevant non-major and minor bleeding was actually increased. Why is it relevant? So I thought this is not what the author said, that this is what I thought, which was, I think this trial at least opens up the conversation for having a discussion about stopping oral anticoagulants for successful catheter ablation. Let's jump back to a little bit more stuff. And you may say, you just got done talking about pulse field ablation, but you're coming back. The reason why I'm coming back is because next week is a big meeting for us in the EP world. It's called the Boston AF Symposium. And we're going to get some more data from, this is what's called the Volt AF IDE. That conference, so in about 5 days, they're going to release a ton more data. So the reason why I want to do this last is because this is something that we're going to actually be getting some data for. So we're really excited to hear that presentation at Boston. So what is this trial? Pulse field ablation again for AFib. And this is utilizing a new technique, which is basically a system that allows us to look at tissue contact, hemolysis, and mapping, integrating these all together. So essentially, a catheter that you can, number one, deliver energy, destroy tissue, map, and one of the problems with pulse field ablation is you destroy a lot of red blood cells in that process. And this trial looks at what is that incidence for this new system. This is one of the catheters that they utilized. So success rates very similar to other pulse field ablation strategies, but they're just not seeing this big difference, which is hemolysis. It's one of the things that we see with pulse field ablation that we have to be mindful of. So this trial, Volt AF, is very exciting, and in about 5 days we're going to have some more. Reset AF trial. This is yet another pulse field ablation. So if you're a stock market person, you should definitely be trying to find a company that's going to win the pulse field ablation war, because someone will ultimately be victorious. Every single company is getting involved in it. So if you have some sort of company, you're getting involved in the pulse field ablation business, and this is yet another catheter. This is more of a circular catheter, and this is a really exciting foray from a company called Biotronic. And essentially, what this trial is looking at is yet another type of pulse field ablation. And so this was exciting in 2025 because this Reset AF trial is another type of catheter. And whoever you use for your electrophysiology will have their favorite catheter, yet another one in the marketplace. We're not stuck in 2025. We're on to 2026. What's in 2026? Some really exciting new trials. This is Cardiology, which is actually a local company in California. They're also coming up with a new kind of pulse field ablation system. It's a multi-electrode. It's like a globe in Las Vegas. It's an exciting catheter on how to perform pulse field ablation. And this is a new clinical trial, which is called Pulse Dynamics Integra D, which is going to be looking at a single transvenous device capable of performing what's called cardiac remodeling and also delivering a shock. So lots of exciting technology. This is how the trial is set up. So essentially, you're going to be seeing companies coming out with smaller leads, able to do more. And this will be coming out in the future. So these are 2 new trials that I'm excited to see. This is all of us. This has to be updated because we require even more faculty. I just want to thank you so much for inviting me here, and if I can answer any questions. Thank you.
Dr. Donaldson, would you mind taking a seat there, and then Dr. Lee, can you just so we can ask a few questions of the experts here? So one question I had was, I think you answered it. You answered it quite